Hi everybody, and welcome to Unit 4, Basic Care and Comfort. We stopped on transferring clients, so we're going to talk about moving clients. When you're moving clients, you have to be alert for any type of a fall. The patient may get dizzy, or if they have weakness on one side, and this could lead to an injury, so you always want to be alert for that. Use caution. Be alert for any hazards that they might catch their foot on that might cause tripping or falling or injury. It's always important to plan out your transfer before you start the transfer. Remember, those who fail to plan to fail. Patients should always have non-skid footwear on. Always make sure that your patients have footwear that is supportive, that won't slip off of their feet. Don't use those little socks that have the no skids on them. They're not really non-skid. And make sure that they're stable footwear. Always be alert when you're moving your client for instability. If they start to feel faint, dizzy, or unsteady, you would want to return them to the bed or chair that you're transferring them from immediately. Always position your furniture, your chair, your wheelchair, where you want it before you start to move your client. Don't start to move your client and then realize you have to move a chair or a wheelchair or whatever. Before you start to move that client, also make sure that the brakes are locked on both the bed and the wheelchair. If that patient has a weak side or a side that they may have some paralysis on, you may find a transfer or gait belt very useful. It can give you a place to grip on that patient to allow you to guide or steady them. Remember, it is a transfer or gait belt, not a lift belt. If you have to lift this patient, you should be using some type of mechanical lift, not a transfer or gait belt. It's not for lifting, and you should never be grabbing a hold of their pants and lifting them by their waistband or pants. First of all, you can tear their clothing. Second, you can injure the patient or cause abrasions or damage or shear damage to their skin. So we don't want that. Some more guidelines for transferring. Make sure that when you're transferring a patient to a wheelchair that you line that wheelchair with cushions, blankets, or padding to prevent discomfort, rub or pinch areas in that wheelchair. We want to make sure that we prevent that. Be aware that clients with a weak side may need adjusted movements as needed. We always want the patient's unaffected or strong side to lead out when we transfer them so that they can lead with that side. Always make sure that you're familiar and properly trained in any assistive devices that you're going to employ. If you're going to use a mechanical lift, whether it's a sit-to-stand, a Hoyer, whatever lift it is, make sure that you've been trained to use it and that you know how it works. And make sure that it's working properly. If that lift isn't working properly, you may end up getting that patient up in the air, can't get them down. Or it may break while you get that patient up in the air, and that patient could be injured. So we want to make sure that equipment is working properly. If it isn't working properly, make sure you mark it correctly, put in a maintenance order to get that equipment fixed, and don't use it again until it is fixed. If the patient, again, if they find it difficult to stand, you can use a gait belt or transfer belt, and you see a picture there of an aide using a gait belt with their patient. Notice that the grip on that gait belt is from underneath with just the fingertips. It's just a guiding grip. It's not lifting. He's not holding her up, just guiding her and steadying her. Before you transfer the client to the chair or ambulate them, make sure you have them sit on the side of the bed, dangle their feet. You want their blood pressure to balance out so that they don't have any dizziness or anything like that. We call that dangling when we sit the client on the edge of the bed. If that patient has been bedbound or on bed rest for a significant amount of time, this is their first time up, it's really important that you let them do that for maybe as much as 15 minutes before you get them up to move them to allow that blood pressure to stabilize. There's also certain circulation problems or medications that can cause that rapid change in blood pressure. We have to be aware of that when we move patients from lying to sitting to standing. If that client, again, as I said, has a weak side, make sure you put the chair that you're transferring to so that that client's unaffected or strong side will lead throughout the move so that they can use their unaffected side to lead them into that move. You want to use your leg muscles to stand up and take your client up with them. Don't really lift them. You're just kind of guiding them and helping them to stand up. If you have to do significant lifting, consider getting an order to use a mechanical lift with this patient. You should not be completely lifting any patient by yourself. Always plan ahead and know what you're going to do in your transfer, and educate your patient about what's expected of them and what you're going to do. They need to be aware of what's going to happen so that they can participate in this move. Be aware that they may get frightened, they may feel anxious, and they could grab your neck. So make sure you tell them not to, but then be ready for it if it happens, so you can calm them down and help them to move through this transfer effectively. If we're transferring to a stretcher, maybe they've just come back from a test and they're on a stretcher going back to their bed, we can use a draw sheet to move the client to the edge of that bed or stretcher if they're going from the bed to the stretcher, or from the stretcher to the bed. The stretcher should be covered with a sheet if we're moving them to the stretcher. We can use a slide board to help move the patient from the bed or stretcher or to another bed. That slide board is that long plastic board that you see the lady holding in that bottom picture. It's slick, and we put that board underneath of the patient and we can slide them across it. They also make roller boards. It has rollers inside of it with like a rubber material over it, and that can help to roll that patient across. Sliding that patient across one of those assistive devices is much easier than trying to lift that patient and move them across. So that's always much more helpful. They also make friction-reducing sheets that we can use to put underneath of that patient and slide them across to that stretcher or to that other bed. So that's another way we can do that. Whenever you're going to transfer somebody from bed to bed or bed to stretcher, always ensure that those wheels are locked on both bed and stretcher. Stretcher and bed should be at the same height, and they should be, when you push a stretcher or take somebody somewhere on a stretcher, always push it with the client's feet forward. You don't want to push anybody so their head is going first, because it can be very disorienting for your patient. But when you're going into an elevator, that's the only time you're pushing it head first. You go head first into the elevator so you can come feet first out and go around into the hospital. When you're going down a ramp, you want to go feet down when you're going down a ramp. When you have a client on a stretcher, you never want to leave them unattended, because those stretchers, they're usually a little bit higher than a regular bed, and they're usually narrower, so we worry about patients having an injury or falling off of those. And again, educate your patient when you're going to transfer them from a bed to a stretcher or a stretcher to a bed. Tell them what's expected of them. Tell them where you want them to put their hands, which we usually have them cross their hands over their chest. Tell them what you expect of them, what you want them to do. Now, repositioning a client, we have, I forgot to tell you, with transferring a client, there's a video that you can watch that shows you how to transfer a client from the bed to a wheelchair. So I want you to go and watch that video. Now, with repositioning, remember that when we reposition our clients, we always follow the body mechanic rules when moving or lifting or repositioning clients, because we have to keep that client in good alignment. If we don't keep that body in good alignment, we can damage joints, we can overstress joints and cause injury. Also, we have to reduce friction, which can cause damage to the skin. So rolling or lifting or using lift sheets or using friction reducing sheets can help us to move our clients without causing damage to them. Now, your transferring skill, which I didn't tell you, is on page 277. And your ambulating, well, we'll talk about ambulating in a few minutes, but your transferring to a stretcher is on page 281. So, some key points about positioning your patients. When you position your patients, check to see if there are any limitations or restrictions in position or in moving that client. Have they had back surgery, which would mean you have to log roll them? Have they had hip surgery, which means that you have to have their abduction pillow between their legs when you move them? What kind of restrictions does that person have? Decide how the client will be moved, how many people you need to help move them, and plan ahead and make sure you have enough help to perform whatever procedure you need to do. Keep the client covered, protect their privacy, pull curtains, close doors, but also cover that patient's body. Make sure they're covered up and to their satisfaction. Protect any tubes or drains or containers that are connected to your patient. If they can be paused and disconnected, that means that you don't having to worry about one less tube. That's always the best idea. Move the patient to the side of the bed before you turn them to give you more room so you don't shove their face into the side rail. They should be in the supine position when you move them to the side of the bed. It always makes it easier. And always move them to the side of the bed in segments. Top half first, then the bottom half. It really should use 2 nurses on the lift sheet, opposite sides of the bed. They should get up as close to the patient as they can, and they should lift and move. Now, when you move someone up in the bed, always make sure there's a pillow at the top, because if you get a little too carried away, you could actually hit that patient's head on the top of the bed, or I have actually seen people hit their head on the wall, which is not good. So we don't want to hit that person's head. We want to make sure that they are protected. Reposition our patients. We want to do that every 2 hours to reduce pressure in the same area and also to maintain skin integrity. We don't want pressure areas developing. As I said, if they are a spinal cord or a spine patient, a spine surgery patient, they have to be log rolled. Body parts are supported in alignment to promote comfort and prevent undue muscle strain. This becomes really important if your patient is unconscious. When they don't have muscle tone, we have to make sure that that person is properly aligned. If they were turning that patient, we want to avoid prolonged flexion of any one body part. If that person is going to contract, they will contract in flexion. So we actually want to keep body parts more in extension than we do in flexion. Alignment can be maintained, and we can avoid discomfort from muscle strain by using supportive aids like braces and pillows, special pillows that help to keep that body in a proper alignment. Now, if you look on page 265 in your book, that's positioning the patient, and they show you all of the positions you can put a patient in and how you would brace their body with pillows. They show you supine, semi-Fowlers, Sims position, which is a side-lying prone position. So they go through all of those and how you would position that patient. So it can be really useful for you. They also show you moving the patient up in bed. And they also demonstrate or show you the log rolling position, both in a diagram and in a picture, and that is on page 271. So take a look at that. That can be really important if you have a patient who had a surgery and you need to move that patient. Now, some other supportive aids that we can use besides pillows, pillows are very good, can be folded, rolled, tucked to give support. We can also use things like sandbags. Footboards or high-top sneakers will put on a patient to prevent foot drop when the toes kind of point, and that actually can cause a contracture in the foot, and they'll have their toe permanently pointed, and we can't actually get it out of that position, which can be very bad. As I mentioned, hand or foot splints to keep those hands or feet within extension and out of flexion, and also hand rolls to keep the hands out of flexion. We can use any of those if they have been prescribed for your patient to help support that person's body and reduce pressure and keep that hand in extension. Trochanter rolls, they actually do have a picture of trochanter rolls in your book on page 264, and they go along the side of the leg to support the hip joint and the thigh. It prevents outward rotation of the hip and thigh and maintains better foot alignment. So we sometimes do use trochanter rolls. So our positions, as I said, if you look in your book, starting on page 265, supine, which is lying on the back, lateral or side-lying is lying on the side, of course, and we use pillows for support when we do that, have patients lying like that. And then prone is with the patient positioned on the stomach. We have to be careful of plantar flexion when we do that, and we may have to put a small pillow below the diaphragm for that patient, and they show that on page 267. They show you prone position with that pillow put below the diaphragm. Any other position that we put people in is a variation on these positions, and they show you a couple of the position variants on page 263. They show you dorsal recumbent position, which is often used for catheters. So when we do a Foley catheter on a female, we use dorsal recumbent. And lithotomy position, which is a supine position with the feet in the stirrups. We use that for a vaginal exam. The dorsal recumbent position is supine with the head flat and the knees up and out to the side. So those are two supine positions. Then there's the knee chest position, which is a modified prone position. They show you that on page 264. The other ones are on 263. And that knee chest position is a variant, patient face down on the bed with the head turned to one side. Chest, elbows, and knees rest on the bed, and the thighs are perpendicular to the bed. The lower legs rest flat on the bed. And that's used for rectal exams. And as a method to restore the uterus to a normal position. And you don't want to leave that person alone because they can become dizzy, faint, or fall when they're in that position. So next we're going to talk about skin integrity and some evaluation. We can evaluate cognitive and physical function of our person and see what we think about how they can maintain their skin integrity. Do they have poor vision? Do they have decreased sense of touch? Do they have limitations of range of motion? Do they have coordination, muscle strength, or balance issues? And all of those could contribute to put them at risk for changes to their skin integrity. Now, one of the things that we use to evaluate skin integrity is called the Braden scale. We also use a pressure score risk indicator. So we use our Braden scale to tell us if if we have a person at risk, and on page 290, they have that Braden scale for predicting pressure sore risk. And the Braden scale looks at things like sensory perception, moisture, activity, mobility, nutrition, and friction and shear, and to see if that person is at high risk. We look at the skin, and we look at red, yellow, and black. That's another evaluation tool. There's pressure score, risk. So there are several different scoring techniques. Braden is one of the most widely used, however. We look at the person's nutrition and hydration. Is this person getting enough fluids? Are they getting proper nutrition? If this person is incontinent, incontinence contributes a great deal to their ability to keep their skin intact, because urine and feces are chemical, and they are very acidic chemical, which can break down the skin. Do they have a lower mental awareness where they're not aware that their skin is breaking down or they're developing a sore? And that can actually contribute. A very good time to do your skin assessment is during a bath, because as we said, everybody takes their clothes off during a bath. And as you saw in that video, we can have skin breakdown very quickly. And so we want to be assessing that before it gets very bad. Some prevention of pressure ulcers. First of all, assessing that skin regularly. Every time we're doing care, every time we're doing baths, we should be assessing that skin so we catch reddened areas while they're still new reddened areas, and we treat them. Repositioning our patients every 2 hours, particularly patients who cannot move themselves. Heels off the bed. We always want to float those heels. We want to put a pillow or a folded blanket, something underneath of their lower legs to keep the heels off the bed, because that can actually develop into pressure areas very quickly. Pressure reducing devices. We have a lot of the air beds that change that air in the mattress, which are very useful, but they are not a replacement for repositioning patients every 2 hours. And a lot of people think, oh, well, they have an air bed, I don't have to reposition them. But that is not the case. So always make sure you're repositioning every 2 hours, even if they are on a pressure-reducing mattress. We want to restore circulation to any deprived areas. We do not ever want to rub the reddened area, but we can actually rub around it where it's not reddened. So you can bring circulation back to the area around a reddened area, but don't ever rub a reddened area, because that's an already place where there's already skin damage, and by rubbing it you could create more damage. Never massage a reddened area, because, as I said, you can cause more damage. Never massage directly over bony prominences. It can cause pinching or damaging to that skin. Always wash and dry an incontinent patient. Don't ever do what I call the diaper wipe, where you just wipe them off with that brief, and then you put a new one on and you're done. Always wash them and dry them to get the urine or feces off of their skin. Avoid mechanical or physical injury from splints, braces, casts, prostheses that do not fit well. Always check those for rub areas, pinching, if they're too tight. Always check those and have them adjusted by the provider. Avoid burns from things like hot water bottles, ice bags, heating pads, heat lamps. We have to apply those things with care and only in the amount of time that's instructed. Ice should only be applied for 10 to 20 minutes every 1 to 2 hours. So no more than 20 minutes at a time, and ice never goes directly on the skin. Ice should always have something between that ice pack and the skin so that it doesn't burn the skin. And you can get a burn from ice just like you can get it from heat. Heating pads should never be left on the skin so the person goes to sleep. Heat lamps, we have to be careful that they're not too close to the person. Hot water bottles, again, we have to be careful of the temperature, that the water put into it is not boiling. It should be not any hotter than what you would put in your bath water. And then proper techniques for positioning so that we're not putting people in bad positions where they can get skin damage, skin breakdown, and adequate nutrition and fluid. If a person won't eat, we always offer them fluids to make sure they get proper fluid intake. Here's your stages of pressure ulcers. Remember that our stage 1 is an area that's red, deep pink, or mottled skin. It can be warm with edema. And you'll see these pictures on 291, so you can look at them. So it's a red area. There's no skin breakage with a stage 1. Stage 2, that's when you start to have skin breakage. It may be blistered. It may look like an abrasion or a shallow crater. There's some skin loss, but it's not all the way through the skin yet. Now, stage 3 is full thickness all the way through the skin. It's getting down into the subcutaneous tissue, and there may be damage or necrosis of that subcutaneous even. It resembles a very deep crater, and you can see where we're getting down into that stage 3. That's a really big wound that they have there in the book. And then we get into the stage 4, and that's just enormous, full thickness loss, extends into the muscle, the bone, supporting structures, and they show you, really huge wound. Now, if it's dry, black in color, you can't see the wound bed, and they show you in diagram E on page 291 in your book, a wound with eschar over the top of it, which is necrotic tissue. When that's present, that's an unstageable wound, and you really have to have that removed, and that's removed by a physician. That's a surgical procedure. And once that's removed, then you can stage that wound. While that eschar is there, that's an unstageable wound. We can't see the wound bed. We don't know what stage that is. And so there's your pictures. The only one that's not present is the unstageable wound in this picture. So that shows you your stage 1, 2, 3, and 4. And those are the same pictures that are in your book on page 291. Now, we can also see ulcers, like what we call stasis ulcers, from venous insufficiency. Patients who are immobile or who are post-operative are at risk for venous stasis. We can have blood clotting, and they can sometimes even get ulcers from venous insufficiency. Blood clots can move and become emboli. A thrombus or thrombosis is a blood clot that's sitting still. An emboli is a blood clot that's moving. Now, in order to prevent those, we may get something that's called an SCD, which is a compression device that actually has air in it and it squeezes their legs. Or they may have anti-embolus stockings, which are also called TED hose, that we put on them. Now, these are the SCDs, they're sequential compression devices, and they have all these tubes that go on them, and they Velcro onto the person's legs. They have a little pump that goes to the bottom of the bed, and they alternately compress and release, squeezing the vessels and propelling blood along the vessels to prevent clots in the leg. We usually put these on somebody directly after surgery when they're in the hospital. They're going to stay in the bed, and we have these on them. Now, generally, they only use these for the first day or two after surgery, when maybe the doctor has said they want them to stay in the bed and not get up. When we start getting them up, we usually switch to anti-embolus stockings. Now, anti-embolus stockings, they come in knee-high, thigh-high, or full length. And the doctor will say, okay, I want them to have knee-high, I want them to have thigh-high, whichever it is. We have to measure the leg length for them, and also the leg circumference based on the size that they've ordered. Of course, if you need knee-high, you only have to have that lower leg circumference, which is the one over here that shows. If it was a thigh-high, you'd also have to measure up here on the thigh. Full length, you might have to measure up higher in the thigh. And then we pick out the size based on what those measurements are, length and width. You can apply powder to help them slide on more easily. Just don't get carried away with your powder. And they have this, you can see in this picture down here, there's a hole. It's like this little blue hole. And the reason that hole goes on the top of the foot, people are like, where's that go? Does it go on the bottom? Does it go on the top? It goes on the top. It goes on the top so that you can check your toes to see if you have capillary refill, see if you have, and then you can pull it down and you can reach up in there and you can check your pedal pulses and see if your pedal pulse, your dorsalis pedis, is present. Because you're going to check your pedal pulses before you put them on, check your capillary refill before you put them on, then you're going to check it afterward and make sure that it stays consistent and equal bilaterally. Because if it doesn't, they're too tight and you need to take them off. You also want to, if you can see in this bottom picture, they're nice and smooth, there's no wrinkles. You don't want any wrinkles in these things. If they get wrinkled or creased, it can actually cut off circulation to the foot. So you always are checking them to make sure they haven't slid down and caused a wrinkle or a crease. You have to smooth them back out again. That's very important with anti-embolus stockings because they can actually harm the legs if you're allowing them to slide down and get wrinkled or creased. And if they're doing that all the time, they either are stretched out, the elastic in the top is too stretched out, and they need to either be washed, which can help them go back into their proper shape, or they need to be replaced because they're too stretched out and too old. If that doesn't work, if they're brand new, then they're not the right size. You need to remeasure because they're not fitting properly. Now, mechanical lifts, as I said earlier, if you're trying to lift somebody with a gait belt, you're using the wrong type of transfer method. If that person cannot stand up by themselves with just guidance from you, you need a mechanical lift. Now, as you see in these pictures, 2 people on a lift, one to operate the lift, one to guide the patient. This lady just looks so happy. But she's just staying there. We use a lift with patients who cannot move or have difficulty moving to and from beds, wheelchairs, tubs. And one person is operating that lift, the other is guiding that patient. Always make sure you check this equipment, make sure it can go up in the air and come back down again before you put a patient on it. Make sure that the bed is locked, the lift is locked. If they're going to put her in a wheelchair, that wheelchair needs to be locked before they, put her into it. Make sure that you always apply the sling correctly according to the manufacturer's instructions. Because if you don't and something happens, it's on you. If you did it correctly according to the manufacturer's instructions, then if there's a malfunction, sometimes we can't help these things, but you always want to make sure you're doing it correctly so that it will work correctly. And generally, if you're doing it according to the manufacturer's instructions, it's going to work correctly. And a lot of these lifts have a lot of bells and whistles. You can weigh your patient while you got them up in the air there in your lift. So if you're always weighing them with the same lift, you can get very consistent daily weights. And they have this nice automatic controls, and you can the lift slings go under really easily. They're easy to get back out from underneath of the patients once you get them in the wheelchair. So some of these lifts are very convenient and very, very useful in helping you get your patients up and keeping them mobile and out of the bed so we don't risk the complications of immobility. So our next one is crutches. Now, if you look at your videos, there are a couple of videos that are about transferring and moving patients, so I wanted to make sure you look at those. There's also a video on crutches. It's a really good video. It tells you about how to size those crutches and how to walk, go upstairs, downstairs, sit down, all the things that a person would have to do on crutches. Now, one of the most important things we do with crutches is size them for our client. The length of a crutch should be from the base of the foot to within 2 to 3 inches of the armpit. You should be able to put 2 fingers between the axilla or the armpit and the top of that crutch. When that person is walking on their crutches, they should not have their weight on the top of that crutch. If they do, they can injure the axilla and interfere with circulation and nerve conduction from that brachial plexus that's underneath of the arm. If they have numbness or tingling in their hands or arms, they should stop ambulating with those crutches because they are actually putting too much pressure on that axilla and they're going to cause themselves circulation or nerve damage. Forward movement with crutches, about 8 to 10 inches is safe. If they're non-weight bearing, it'll be a tripod stance. and they move their uninjured foot and the crutches forward, and then they should take a step forward with their uninjured foot and then move forward with the crutches again. And they should always look up and out when they do that. As I said, 2 finger widths between that top of that crutch. Elbows should be slightly flexed, about 20 to 30 degrees. And they should be supporting their weight on those hand holds, not on the top of the crutch with their axilla. They actually should be squeezing the top of that crutch between their arm and their body. When you're walking with somebody with crutches, stand on their affected side, on the side of their injured foot, so that if they start to go down, you can support them. Always instruct them to look up and out, not down at their feet. And they should always stop ambulating if they get any numbness or tingling in their hands or arms. When they sit down with crutches, again, place their unaffected leg against the front of the chair, move the crutches to their affected side, grasp the chair's arms. They always need to reach back and feel the chair. Grasp the chair's arm with the hand on the unaffected side, flex their knees, bring their affected leg straight out, and sit down. And then the process reverses to stand up. With down the stairs, remember it's down, up with the good and down with the bad. And if you watch that video, they go through both a set of stairs with handrails and a set of stairs without handrails. It's a very good video that will show you exactly how to do stairs with crutches. Now, walking with a cane, remember that a cane is held at hip level. The same bend to the arm as with crutches is what you want with a cane, about 20 to 30 degrees. So most canes, you can see with these 2 canes in this picture, they're adjustable. So we want to adjust that cane to the proper height for our patient. Now we've got a quad cane here and just a single ended cane. It can be either one, so the quad canes are for a little more balance. But we want to check the rubber tips on the cane to ensure that it's in good condition. Sometimes they can dry rot, and those can be replaced. But the height of the cane should cause that arm to bend slightly while that patient stands erect. And with a, oh wait a minute, I'll go back on that. With a cane, that cane should be held in the patient's strong or unaffected side. So if their right foot is injured, the cane goes in the left hand. If the left foot is injured, the cane goes in the right hand. So the opposite side from their injury is how we do with canes, so that it can help them to walk. When that affected foot goes forward, the cane goes forward. So that's the way that they do that. I will put up a cane walking video too, so that you guys can look at that. It's a real short one. Now with a walker, same thing as with a cane. The height of the walker causes the arms to bend at about a 20 to 30 degree angle, and the patient should stand erect. They shouldn't be bending over to get down to their walker. They need to stand up and stand into the walker. A lot of times people will push their walkers out in front of them like they're pushing a shopping cart, and they shouldn't be doing that. They need to stand in the curve of the walker, move that walker forward about 6 to 8 inches, and then step into it. Move it forward, step into it. If they're only using one foot, then they can move the walker forward, move the walker forward, hop forward, and they can do it that way if they only have one foot to use, or they can just take steps forward if they can use both of their feet. But they shouldn't be pushing it way out in front of them. If it's got wheels on it, then they shouldn't be pushing it like a shopping cart either. Now that brings us to pain. When we're assessing pain, first of all, if you're looking at your patient and you're saying, oh, well, they're grimacing, they're crying, maybe that patient's in pain. Let me offer some pain medications. First of all, we don't want to assume that our patient is in pain. Maybe your patient got some bad news. Maybe your patient learned something that made them cry. So maybe we want to just ask them, I see that you're crying. Please tell me what's making you cry. So we really want to ask our patient to give us information instead of assuming, hey, you want pain medicine? Never assume that your patient is in pain because of what you see. Ask your patient to give you information. We want to assess pain, but we don't always want to just immediately believe patient has pain. Let the patient tell us what's going on. Just observe what you see and let the patient give you the story. Don't give them the story. So now if the patient says, hey, I have pain, now we can assess that pain. So, okay, so where is your pain? Now they can give us some information. Well, they can tell us where it is. Then we can say, okay, so what's the intensity of your pain? Now sometimes the doctor will give us pain medication. It's like, okay, well if they have this mild pain, we can give them Tylenol. If they have really severe pain, we'll give them this higher level. So we may have to assess the intensity before we can give our pain medicine, because that pain medicine may be based on, well, how bad is this pain? Is this just a 3 pain? Well, maybe that just needs Tylenol. But is this a 9 pain? Well, maybe that needs Percocet. So let's talk to the patient about how bad is this pain. On a 0 to 10 scale, 10 being the worst pain you've ever had in your life, 0 being no pain at all, where is this pain? And let them tell us how bad this pain is. Now, some people, hey, if I cut my finger, that's a 10. For some people, well, I broke my leg, but it's really only a 6. Whatever that patient tells us that pain is, that's what that pain is. Everybody's perception of pain is different, and we should respect their perception of that pain. What is that pain like? Is it sharp? Is it dull? Now we can just ask the patient, can you describe your pain for me? Now sometimes they can tell you, oh yeah, it feels like an elephant sitting on my chest. But if they can't give you words, then you can ask them, is it dull? Is it sharp? Is it shooting? Is it radiating anywhere? Give them some examples, but we really want them to paint that picture of the pain for us. We can ask them, how long have you had this pain? Have you had it continuously, or does it come and go? How long does it last if it comes and goes? So duration, frequency, intensity, location, all of these are really important things that we need to know about this pain, because that can tell us something about what's causing it. Now, remember that pain is what the patient says it is. Pain can be affected by culture, age, level of consciousness or awareness, race, sex. Men tend to be more stoic. We tend to tell males, oh, you can't cry, you're not manly if you cry. And so a lot of times men in certain cultures tend to be more stoic. Certain cultures tend to be more stoic where others are more demonstrative. Older people tend to have more comparison for that worst pain you ever had in your life, where younger people don't. So this new experience of this pain may be the worst they've ever had in their life. So there's a lot of things that can come into your perceptions of pain. Now, pain can be acute, which means it's lasted less than 6 months, or it could be chronic, lasting more than 6 months. Some things that could indicate pain, maybe if a patient can't really talk to us or isn't sure about pain, we might see in that patient moaning, crying, irritability, inability to sleep, grimacing, restlessness, rigid posture. We can see elevations in their vital signs of blood pressure, pulse, respiration. People can get nausea or diaphoresis from pain. So all of these are things that we can see in that patient's behaviors or actual vital signs that can show us that that person is physically in pain. Some myths that we have about pain. When doctors and nurses gather information on new patients, pain's the least of their concerns. Well, pain isn't the least of our concerns. It is counted as one of our vital signs. However, in an emergency situation, pain, we actually look at pain like a psychosocial concern rather than a physiologic concern, because people don't die from pain. People die from the things that causes pain, but we can't treat pain and cover the cause of it. We have to make sure we assess it in a way that we figure out what's going on, and then we can treat it. So sometimes people feel like maybe we didn't treat them as fast as we should have, when in actuality, we're simply not treating their pain until we make sure we've assessed it properly. And so sometimes people feel like it was our least concern, but really it was just that we were trying to treat the underlying cause of the pain first and make sure that we didn't let it kill them. For number 2, emergency department doctors avoid giving pain medications because it can make the physical examination more difficult. Well, it's actually a myth that it makes the emergency department examination more difficult. We don't want to mask symptoms, but once you've figured out what's going on, you've done some assessing, giving someone some pain medication can actually make it better. We don't want to mask the symptoms, and we want to make sure we do an accurate diagnosis. We also don't want to mask our ability to do the proper testing. Sometimes we have to give pain medication in order to allow people to undergo testing, but sometimes we can't give pain medication so that people can undergo testing. So it just depends on what's going on with the person and what their condition is. Myth number 3, the medication often used for pain relief causes bad side effects and may lead to addiction. Well, actually, addiction to pain relief medications is rare if they're used properly, as prescribed, and taken as directed. Also, a lot of the medications that we use nowadays are a lot safer, and there are protocols that encourage adequate dosing if they're prescribed correctly, tapered off when they're not needed anymore. There's very small possibilities of addiction. It's just when they're not used properly that there's a lot of chance of addiction. So the whole thing about, oh, they're going to get addicted, they'll become a pain pill addict, it's a lot more hype than really true. Myth number 4, pain relief usually means injections of medication. Some people do need things like morphine or IV pain relief, but it's not necessary for most small injuries. It just depends on the patient and the complaint. Number 5, I won't be able to handle the side effects. It'll make me dizzy, drowsy, feel like not like myself. Some of the most common side effects are drowsiness, constipation, nausea, vomiting. And those are opioid pain relievers, but they can usually be treated very successfully. Usually they'll give people Zofran along with those medications, and they'll do just fine. Pain is an inevitable consequence of cancer. Actually, there are a lot of cancer patients who never experience pain. Cancer pain can be relieved safely and effectively. And number 7, I should be able to tolerate the pain. A lot of people, their culture, their family backgrounds, religious or moral beliefs lead them to think that you're weak if you have to take pain medication. I can tough it out. But pain is something that, if you can't tolerate it, and in fact, pain is your body saying there is something wrong with me, do something. If you need pain medicine to get through whatever your illness is, it doesn't mean you're weak. It simply means that your body's alarm system is going off, and we have to do something about it. It's not any different than being in a building where the fire alarm is going off, and it kind of makes you feel like your head's going to explode. If you have to take pain medicine, you have to take pain medicine. Number 8, my doctor won't understand my pain. Some people are afraid healthcare professionals will think they're exaggerating or they're being a chicken. But it is your right to receive assistance with pain management. If your doctor doesn't understand, then you need to seek a new doctor. Your doctor's problems shouldn't be your problems. Excuse me. Number 9, if I complain I'm not being a good patient, you have the right to be treated properly. You're the best judge of your pain. Nobody else can feel your pain. And the better you describe it, the more helpful it will be. It could help keep a record, keep a pain journal, rating the pain and what you've tried for relief so that you can talk effectively about your pain with your doctor. Pain management clinics can be very helpful for people with chronic intractable pain. Pain means my cancer is getting worse. For people with cancer, some people think that it's a sign of deteriorating health. Actually, with some illnesses, it can actually mean that it's getting better. For severe burns, even some cancers, it could actually mean that this condition is stable and that their life expectancy is long or it's better. So it doesn't always mean that whatever you've got is getting worse. This is the pain scale. These faces are actually called the Wong face pain scale. I've actually seen these done with 0, 2, 4, 6, 8, 10. So you can use them like that, or you can use them on a 0 to 5 scale. But these are a lot easier for children to understand. We usually use the 0 to 10 scale, but always just put it as a fraction over whatever your top number was. So I know if you tell me 5 out of 5, that was really a lot. Or you tell me 5 out of 10, well, that's about halfway. Some of our non-pharmacological interventions for pain, we could allow that person to do progressive muscle relaxation, massage, like a back rub or something like that. We sometimes use a TENS unit, which gives electrical stimulation. And that can be useful to basically distract the nerves. And it also helps to loosen up muscles that are tight or cramped up. Heat and cold applications can help to reduce pain. Music, biofeedback, guided imagery, or education can all help the person to deal with pain better, distract them from the pain. That can really be helpful. Some things that we can do to help people in pain: make sure that bed linens are straightened, reposition tubes, or make sure they're not lying on objects that can cause them to be uncomfortable. Warm blankets if they're cold. If the bandages are too tight, loosen them up. Dressings that are moist, a lot of drainage, they're uncomfortable, change them if they become soiled or full of drainage, so that doesn't feel uncomfortable for them or could cause pain. Check tape. Sometimes there's, this bandage is hurting me terribly, and it's tape pulling their hair. Make sure that the patient is positioned in an anatomic alignment. If they're positioned in a way that it's putting stress on joints or stress on their body, that can actually put them into pain. Check the temperature of when we're putting on hot or cold to be sure that it's not too hot or too cold. And that includes bath water. Make sure that when you're moving patients up in the bed, that we're lifting or using friction-free sheets to move patients up in the bed so that we don't injure them and that we handle them gently. When you're putting patients on a bedpan, make sure that you put them on correctly, because that can be painful. And make sure that you only leave them on the bedpan for a short amount of time. Don't leave them on there for a long time, because that can be very painful. Avoid exposing the skin or mucous membranes to irritants. So don't leave diarrhea, stool, or wound drainage on the skin, because it can actually damage the skin. Encourage them to intake enough fluid. Encourage them to intake the proper amount of fiber in their diet and get enough exercise to prevent constipation, which can cause pain. Remember that whatever you do, whatever non-pharmacological interventions, you should within 1 hour reassess them using the pain scale to see if it was effective. When you give pharmacological interventions, you should always assess them within the amount of time that that medication should work to assess their pain and see if it worked. We can observe their facial expressions, body language, position, mobility, relaxation, describe their ability to rest, sleep, eat, participate in usual activities. That could be a description of how well that medication or that intervention has worked. And of course, rest and sleep is an important part of this patient's ability to be comfortable. Rest is when you feel mentally relaxed, free of worry, and physically calm. Rest is being free from mental and physical exertion. So remember that if your patient is on bed rest, your doctor wants that patient to rest, be free from mental or physical exertion. If they've got family members in there bothering them, calling them on the phone, telling them all kinds of problems, fighting with them, they're not resting. So you may have to be the one that tells the family members, visiting hours are over, you need to leave, our patients need to get some rest. You may have to be the bad guy because the patient may not be able to tell them to get out. So it may have to fall to you to be the person to do that. And emotional or metabolic stressors may also cause a person to be very restless and not able to actually rest when they're on bed rest. Sleep is a state of rest that occurs for a sustained period. It's believed to be when we do our healing, our recovering of our cells and things like that. Achieving optimal sleep quality is very important to our recovery. So it's important that we make sure our patients can sleep, which we don't do a very good job of because we stay up on night shift and we make noise and we run machines. And we do all kinds of stuff that can keep our patients up. Some factors that affect their sleep: illness, things like pain, position, or fear, anxiety and depression. People who are depressed can sleep a lot or not sleep at all. People with anxiety can have difficulty sleeping. Certain drugs or substances can keep us awake, like caffeine, nicotine, energy drinks. Too many energy drinks during the day can keep you from sleeping at night. Lifestyle, rotating shifts, like sometimes you work days, sometimes you work nights, sometimes you work evenings. Your body just doesn't even know when it's supposed to sleep. Change in meal time, so you don't eat dinner at one specific time, you don't eat lunch at one specific time. Your body gets confused, it doesn't know when it's supposed to sleep. Stress, exercise, and fatigue. And sometimes you're too tired to even sleep. That can happen to people. Changing sleep patterns. Most people have a starting time and a duration that's set, and if that keeps changing, it throws your body off. There's an increased tendency of sleep between 2 and 7 a.m. for everyone. It's part of our circadian rhythms. If you sleep later one day, you may have trouble falling asleep the next night, so you fall asleep later the next night, and so it's hard to get back into your rhythm. If the environment where you're sleeping, the ventilation, the lighting, or the sound, if there's changes in it, it may be difficult for you to sleep. They've actually done studies with the lights on the VCRs, and just that little blue light that might be blinking or something, they've actually shown that that can interrupt the person's sleep. If there's sounds or a radio, it can actually keep you from resting properly. The presence or absence of your partner, so if you're used to sleeping with somebody and they're not there, or you've just gotten married or just moved in with somebody and now they're sleeping with you, that could actually throw off your sleep. Nutrition. Actually gaining some weight can cause you to sleep longer periods, and losing weight can cause a reduction in your total sleep. In order to promote sleep, a quiet and undisturbed environment can cause the least interference. Providing comfort measures like toileting, back rub, or a comfortable bed. Decreasing the noise in the environment from things like conversation can actually promote sleep. If you're going to ambulate your patient, make sure you do it early in the evening. Providing an uncaffeinated beverage, warm milk is supposed to be one of the best things because it actually releases a soporific when you warm milk. It's an enzyme in it that causes people to sleep. Perform all procedures prior to 9 p.m. if possible, so that your patients can settle down for sleep. And that is going to do it for this section. If you want to look at some of these procedures, as I told you, in chapter 19, you're going to see this pressure ulcers and preventing pressure ulcers. You'll also see your administering a bed bath on page 295, so you want to go over that. You saw that video in class. You'll also want to go over your providing denture care, which is on page 304 and 305. And then look at all the videos that I put up on Moodle. Thank you. I will see you guys on Monday.